I thought I had a picture of that. Nope, I must have taken it out. But what they do for a TURP is they put a scope in there that has a cutting blade on it, or a cutting loop, and then a little suction thing. And they go up there and they roto-rooter up there at the bladder neck, and they rode through the ureter. They'll get to the prostate there. Okay, they'll roto-rooter it, and then they pull it out, and it's done with visualization because they look up through the scope. And that's been the gold standard. But now they're doing some things with laser surgery that is causes less problems, less blood loss, less pain, less time in the hospital. But it still does have some problems. All right. So they can also do a transurethral incision, where they go up and they cut small incisions through the urethra and scoop stuff out. They can do a suprapubic prostatectomy, where they take out part of the prostate. The suprapubic and the retropubic, they have some of the most problems with bleeding and some of the longest healing times because they tend to be open surgeries. And the perineal prostatectomy is where they go to the area between the scrotum and the rectum, and they make an incision, like an episiotomy, but there's no introitus there for vaginal opening. So they do an incision there, and then they go up that way. They do an incision. I just can't imagine. They do an incision, then they put in retractors, and they open it up. I'm like, really? How open are you going to make that thing? And then they can do a robotic or minimally invasive procedure. Not every facility is going to have a Da Vinci, but that's a robotic kind of thing. Look on page 959 at that table, and I think there's some pictures too that show you what they're talking about and the approaches. Really, what I want you to understand is what the possible complications are and what nursing care is for that. Continuous bladder irrigation. There's a video. You guys should have access to a video of this through your LWW The Point. If you go to this chapter, and not in your Prep U, but in your book ancillaries, I believe there's a video about this. Now, when they do a TURP, they go up there, or when they do surgery, and they're taking out little pieces, they don't go in there and they don't cut out a big old hunk of the prostate all at once. They tend to take little shavings till they get to the point where they think it's going to be where it's enough. So they might leave little chunks of prostate, little shavings of prostate in there. And there's also the bleeding issue, where you don't want somebody to develop clots. They're going to block their catheter, because they're going to have a catheter. Regardless of the approach, they're going to have a catheter. But you don't want them to develop clots that are going to cause a blockage of the urethra. Okay? So you put in this 3-way urinary catheter that allows them to continuously irrigate that bladder. All right? And it's a 30 French. It's a 30 French catheter. It's put in when they're asleep. Okay? And it's not... And then it's a big old catheter, and it's got 45 ml retention balloon, and they pull it really tight, so it kind of tamponades up there so that it's a decreased bleeding. And then they tape it to the abdomen or the thigh. If they tape it to the thigh, you have to tell the patient to keep their leg straight. Because it's got pressure on the bladder neck outlet there, they're going to feel this continuous urge to urinate. The other thing that happens is because of this continuous irrigation and the irritation, they can have bladder spasms. And what they do is they give them an antispasmodic medication called BNO suppository. And that's a belladonna and opium suppository. And belladonna slows down, is a smooth muscle relaxer, okay? But, and then the opium can act right there where the pain is. Okay, they can also get IV or PO meds for the pain. when you have this, what kind of solution do you think they use to irrigate the bladder? What do you think the irrigant is? What? It's got to be normal saline. Usually it's normal saline. You don't want it too warm and you don't want it too cold. It needs to be, you say room temperature. What's room temperature? In here, I think it's about 110 degrees. What's normal room temperature? 70, 74. What's your body temperature? What do you think their temperature is right there at their bladder? 97 to 99, and you're going to put in water that's 70 degrees? That's not good. It needs to be warmed up a little bit, okay? They tend to keep that irrigant in a little warmer, because that can cause some discomfort. All right, so this little picture here tells you about post-operative care for a TURP. A lot of this post-operative care that you see here is also appropriate for any kind of prostatectomy, where they go in and they actually do surgery on the prostate, okay? Now, when they're doing that continuous bladder irrigation, the irrigant that you see down here, you want it to be a light pink to a dark pink color because they're going to have bleeding. If it starts getting dark red or has the consistency of ketchup, then they're bleeding too much. Okay? So you have to be really careful to monitor that. And you can actually increase and decrease the flow of the irrigant depending on how much they're bleeding or how much blood, what the color of the urine. All right? Now, when they had that catheter out, for one thing, it's a large diameter catheter, and for another, they've had this pulling on their, the traction, so they're going to have some problems with urination strep. First off, they've shaved off part of this prostate, okay, and then they've manipulated that bladder neck outlet. There's a lot of problems with urination afterwards. They tend to dribble or have some incontinence. So they need to start Kegel exercises, just like women do after they have babies. You got to teach men how to do the Kegel exercises. And it's the same kind of thing, like they're feeling like they're stopping and starting their stream. They do have some, a lot of times when men are going in for prostate surgery, they will send them preoperatively to physical therapy, and physical therapy will teach them how to do this. And there's actually and they do this for women too who have incontinence. There are several things that they can do to help make sure that the patient is doing Kegel exercises appropriately. And so they can measure the pressure that they do, and they can also use this electrostimulation thing that looks like a probe. It's a probe, and they put it up for women in their vaginal canal, or they can put it in their rectum, and for men it goes in their rectum and it stimulates the muscles to contract. And they do that for like 15 minutes every 4 hours. Once they're healed enough to do that, or they might do it before surgery to build those muscles up, so that when they get out they don't have the problems. Okay? A lot of patient teaching about how to care for themselves. Also, a lot of times after they have prostate surgery, there's a problem with erectile dysfunction, and sometimes that goes away and sometimes it doesn't, depending on if the nerves were damaged. So post-catheterization care, when you take that catheter out, like I said, you can have some problems with dribbling and leakage frequency. They should subside, and they can also have bladder spasms. Depending on the approach and how much of the prostate was taken out, you cannot use B&O suppositories for bladder spasms for all prostate surgeries. It's usually okay for people who have TURPs and for people who have minimally invasive surgeries, but for people who have the perineal approach especially, no, they cannot have the B&O suppositories. Also monitor fluid intake. Now, prostate cancer is actually the most common cancer in men in the United States. But The good thing about it is it tends to be, most prostate cancers are slow growing, and there's none of this willy-nilly metastasizing. It tends to metastasize in the pelvic girdle area, in the lymph area, and in the bones down there in the pelvic girdle area. Usually the first symptom is similar as the BPH. So if somebody comes in with those types of symptoms, they need to be screened, they need to be tested for prostate cancer if they have an elevated PSA and if their digital rectal exam is abnormal. Now there's different recommendations. Of course, you know, if you've been paying any attention to recommendations for cancer screening, you know, women, they've changed how frequently and at what age you should start getting pap smears and also mammograms, right? They've changed that. For men, it used to be that once you reach the age of 50, you got a PSA and a DRE every year, no matter what. And what they're finding is that there were too many false positives. And I want you to think about this because everybody says, oh, you know, I want to get screened because I want to know. It's a screening test, not a diagnostic test. So if you go in, to have a screening test and it comes back positive, you have to do other tests to do a diagnosis, right? So you're a guy, and you come in, and they do the screening, and your PSA is elevated, which is a fairly, you know, not very reliable test for prostate cancer because there's a lot of things that can cause your PSA to elevate. And then you have to have a DRE. Well, unless you're having a DRE done by a doctor who saw you the year before and actually remembers what your prostate feels like, then it's not reliable. Okay? And so then they have to say, oh yeah, you know what? You had a high PSA, and I think that I felt a nodule. So we're gonna do a biopsy, or we're gonna do a rectal ultrasound, a rectal probe ultrasound. What do you think their anxiety level's like? And I'll tell you this, my doctor my doctor just flips because I'm 52 and I get to have a colonoscopy for cancer, for colon cancer. You know why? I have freaking no risk factors except for I'm overweight. There is nobody in my family that's ever had colon cancer. Nobody in my family who's had any GI cancers ever except for my mother's second cousin. I don't have any I do actually eat not red meat every night. So I'm very low risk for that kind of stuff. And my doctor's like, well, you need to have a colonoscopy. Well, I had a colonoscopy when I was 46 for, another problem. I don't think I need one for another 10 years. And it's the same thing for mammograms. I have no family issues with mammograms. With breast cancer. So I take my personal risk and say, I don't need this every year. I don't need the possibility that they're going to find a cystic area that they want to put me in the hospital or make me do a same-day procedure, right? So they've changed the recommendations that unless you're high risk for prostate cancer, i.e. over the age of 50, African-American male, and a first-degree relative that has prostate cancer, you don't need it every year. I actually think it's because they can't afford to do it for everybody every year anymore. Because that's one of the things that insurance pays for. Does that make sense? So, but what they're finding out in research, they're finding out that the false positives are causing more stress and more health issues than the number of people they actually find early. And did you know that with prostate cancer, like women, there's that BRCA1 gene. There's a BRCA gene for men in prostate cancer. I want all these men that have the BRCA gene for prostate cancer to go get their prostate removed prophylactically. I'm kidding. I'm kidding. That would not be appropriate. All right, so we looked at this. I already talked about the DRE, the prostate-specific antigen, and a biopsy. You have to have a biopsy to confirm it. Now, this is what I wanted to show you. the difference between what prostate cancer and BPH looks like. This is BPH over here. It's on the inside wall, right? Bless you. It's on the inside wall where it lays up against the urethra, and it's a hyperplasia, so it tends to be firm but regular in texture when you're feeling it. When you're feeling it. The cancer, on the other hand, feels like a stone. It feels like a rock, and it tends to be on the outside. And if you have to have a doctor. This is another thing about digital rectal exam as a screening method. You have to have a doctor who's willing to get up in there and feel that person's whole prostate well. Okay? And I'm sorry, a doctor who does that is not going to have many people coming back for a repeat prostate exam. Do you think? All right, surgical management, again, it's a lot similar to what we do for BPH, but they tend to be radical prostatectomies where they take out most of the prostate instead of shaving parts off. Okay? Something else that they'll do is because prostate, just like in women, growth of cancer is dependent on hormones a lot of times. So with men, they're going to take out those organs that produce the hormones, and so they're going to give them an orchiectomy. Do y'all know what that is? What? It's right there, orchiectomy. Orchiectomy is where they take out the testicles. It's a surgical castration. Okay? That has huge body image issues for men. Huge. You need to talk to them about their preoperative care. A lot of times they'll be given anti-androgens before they have the surgery. A lot of times, if the fella is in their 60s and 70s and it's a non-aggressive type of prostate cancer, they'll just watch them because it grows so slow and it metastasizes so slowly that there's no point in doing the surgery. Okay, so they'll do this watchful waiting kind of thing. And if they start having problems with the urethral compression, then they'll go in and they might take part of it out instead of doing a radical prostatectomy if it's not an aggressive form of prostate cancer. Okay? So post-operative care for radical prostatectomy. What's a radical prostatectomy? They take it all with all the lymph nodes, and it's very invasive and they can actually, depending on the approach, damage the nerves. Then innervate the pelvic floor muscles that help with continence and also with sexual function. So, of course, you got to keep them hydrated with IV therapy, and then the regular stuff, caring for the wound drains, preventing emboli, preventing the pulmonary complications. One of the things that we do in the hospital when we have a post-op patient, we do that in spirometry and the foot pumps, right? Just because they have on the stockings and the compression devices doesn't mean that they shouldn't still do foot pumps. And so you tell your patient, that morning when you go in there, you do a little patient education, you say, every time you have a commercial on, pump your feet and do your incentive spirometry 3 to 4 times instead of having them do 10 at the top of the hour. Because some of these people are older and they can't do that. So if you have them doing it every 15 minutes or when commercials come on, they can tolerate that better. Antibiotics and, of course, the analgesics. And a lot of these will get the three-way catheter. A lot of men who have radical prostatectomies or more invasive procedures are going to go home with their Foley catheters or do in and outs when they get home. So you have to teach them how to do that. You have to teach them how to manage leg bags and also how to do in and out catheters if they need it. Now, the difference between putting a catheter in somebody in the hospital and somebody who does the in and out cath at home is it is a clean technique at home, not a sterile technique, and they can reuse catheters. They just have to boil them, I think it's for like 5 minutes, and let them dry completely. They also can get antispasmodics to prevent bladder spasms while they have that catheter in. Bless you. You guys are a bunch of sneezy people today. All right, complications, urinary incontinence and erectile dysfunction, the ED. The ED can last up to 6 months, and then some people can recover depending on if they've had, I don't know what's up today with the meandering in and out of class, but I wish I would stop. Okay, there's been like 10 of you meandering in and out of class today. Stop. Urinary incontinence, if they practice their Kegel exercises and stuff like that, then they can take care of that. And bladder training, erectile dysfunction can last up to 6 months. Some people can recover, some men can recover depending on if nerves have been damaged. There's a nerve plexus down there. If it's not been damaged, if those nerves have been spared, they can spontaneously recover function. But those who don't, those nerves, what those nerves do is they stimulate the release of the nitrous oxide that allows the smooth muscles to relax and blood to flow into the penis for an erection. ED meds do that. So they can use ED meds to fix that, okay? Possible nursing problems associated with any kind of prostate surgery in men, risk for sexual dysfunction, fear, deficient knowledge, because this isn't something that everybody talks about on the street corner. Pain, urinary incontinence, what else? Body image issues. What else? Risk for infection. A roll problem. Now, one of the things I want you to think about is Cynthia brought something that reminded me of something else, is the body image disturbance. Now, they can have body image disturbance because they have scarring or if they had to have an orchiectomy. But sometimes adjunct therapy to surgery is taking anti-androgens. And anti-androgens are going to decrease the amount of their male hormone, so they might develop some female characteristics. Right? Like, what's her name now? Caitlyn Jenner, she takes anti-androgens. Is he going back now? Oh, for God's sake. Okay, anyway, I don't care. That's not the point. The point is that the anti-androgens can cause, decreased facial hair growth, decreased hair growth on the legs and in the chest and stuff like that, and also gynecomastia, okay, and impotence, and decreased libido. All right, so patient education, we talked about this already. Catheter care, self-catheterization. You don't want them to strain when they have bowel movements because that can cause some problems with stitches and healing. So you want to make sure that they take their stool softeners and do other things to prevent constipation. They're not allowed to have intercourse, engage in intercourse for a certain amount of time afterwards. It depends on the approach and how much of the prostate they have removed, if they can, okay? There was something else I was going to talk about. I can't remember. I'm sure it'll pop up. Non-surgical management includes radiation therapy, hormonal therapy, the anti-androgens, chemotherapy, cryotherapy where they freeze it instead of taking it out, and then, of course, complementary and alternative therapies like acupuncture and those CAMs that we use, complementary alternative medicine. Now I find this absolutely fascinating to me because what they do is they can actually do what is called brachytherapy. Most of the time when we think about radiation therapy, we think about radiation beams going from the outside in. What they're doing here is they're actually implanting a whole bunch of low radioactive seeds here in the prostate, okay? And they're low radioactive. They have like a 2-month half-life, a 1 to 2 month half-life, and they're not, they can't damage or hurt people around them. And it's actually a better way to get the radiation because it's very pinpointed, of course, because they're only in the prostate. Whereas if you have the external radiation, it can damage whatever it goes through. I just think that's cool. So this right here is a template that they have mapped out by doing imaging studies of this individual's prostate. They've mapped out where they need to put these. And so they stick a needle through the template, and then they do a train as they pull it out, they drop the seeds as they pull that thing out. Is that not cool? I think that's so cool. Apparently it's very effective for small tumors and has very low complications like the erectile dysfunction and the problems with urinary incontinence and pain and stuff. Isn't that cool? Like, who developed that? I bet you they're rich. All right, we're going to do